Black Diabetic Info is informing you.
Hi and welcome. I'm Dr. Felissa DeRose, your host here at Black Diabetic Info. Today's segment is A Chat with the Pharm D. And today, our guest is Dr. Kimberly Lewis. Welcome.
Thank you.
So can you tell us a little bit about who you are?
Well, I'm Kimberly Lewis. I am a pharmacist. I've been a pharmacist for about almost 6 years now. I am originally from Mississippi and have fallen in love with diabetes because my mother is diabetic. So it's really something that's very near and dear to my heart. I am a faculty member at Campbell University up in Buies Creek, North Carolina. And I work in Fayetteville at Southern Regional Area Health Education Center, or SHREHEC or FAHEC, depending on who you ask.
Okay. So my first question is, what's the difference between a Pharm D and a pharmacist?
Well, right now, all pharmacists are Pharm Ds.
Okay.
About 10, 15 years ago, people would graduate from pharmacy school with a bachelor's in pharmacy.
Okay.
And had the option of going back to get a doctorate. But now everyone that graduates from pharmacy school has a doctorate in pharmacy.
Okay, good. Well, Dr. Lewis, the first question that we have for you is about diabetes. Can you just tell us from a pharmacy standpoint, how does diabetes work?
Okay, so you have two types of diabetes, type 1 diabetes and type 2. For type 1 diabetics, the pancreas does not make enough insulin, doesn't make insulin at all, so they have to have insulin as their means of treatment. But for type 2 diabetics, the pancreas makes the insulin, but the body doesn't know what to do with it. So you have insulin that's just floating around, not allowing the sugar to go into the cells where it needs to be. And we have what's called insulin resistance. So the body has insulin, but it doesn't have an action.
Oh, all right. So the next question that I have here is, are all diabetic medications the same?
No. Simply put, no. Many of them work in different parts of the body.
Okay.
So as I showed you earlier, many of them work on the pancreas. Will only work in type 2 diabetics because they actually have insulin in the pancreas.
Okay.
They work to squeeze the pancreas and make more insulin. Some also work on the liver. The liver actually makes sugar when the body doesn't eat and when it senses it's starving. And then some of them also work on the small intestine. So when we eat, the body digests the sugar and is absorbed in the small intestine. The sugar is absorbed there, so it doesn't necessarily want the sugar to be absorbed, so it doesn't make the sugars higher in diabetes. Okay. So some block the absorption. And then you have some that actually works to make you feel fuller quicker, so you don't overeat.
I think that's what I was on. It was this. Can you tell us about this?
Yes, so this is Byetta. It is an injectable, so you have to stick yourself in order to use it. And it works on what we call GLP-1, which triggers the brain that we're full.
Okay.
So you inject it 30 to 60 minutes before eating, so that when you sit to eat, you don't overeat, and your body senses that it's full quicker.
Right.
And it also stops that sugar from being absorbed that you do eat from the intestine. And the biggest side effect with that is nausea.
Yep, I felt nauseous.
And it's because of how it acts, and we give it to you before you eat. Okay. So that you don't overeat.
Right, right.
So, and also it causes some weight loss, and we don't know whether it's from the nausea or if it's from the actual medication and how it works.
I would say both. Okay. So I see here you have an array of medications. Can you tell us about these? Like, why would someone be prescribed pills? I've been on injections, and I've heard people say, oh, I would never inject myself, and because I was given injections, I thought, like, well, what's wrong with me that I have to be on medication with an injection and someone else can just take pills? So why is that the case?
Okay, so the difference and the main reason that someone would get an injection versus a pill would definitely be the numbers. And we don't like to treat the numbers, but that would be one of the true indications for why we would give someone an injection versus a pill. So for higher numbers, and that's the blood sugars, or even the hemoglobin A1C, which is that average over 3 months, we would want to start you on an injection. Is that a bad thing? No, because it's going to help us get your sugars under control faster, and you definitely could possibly come off of the injections.
Okay. So tell us about the pills. What do they do?
All right, so there's different types of pills. This one specifically is metformin, and this one stops the liver from making sugar. Okay. So you don't get that extra sugar floating around in the blood to make your sugars high when you check your finger.
Okay.
So this one makes you stop making the extra sugar and also makes your body sensitive to the insulin that's produced. There are also other oral or pills that can make your body make more insulin. Okay. Can also stop the sugar from being absorbed in the body. Okay. And also help you to put all of those together. So there are a couple of medications that work in 2 or 3 different spots.
So now, is it possible to be on an oral medication and an injectable?
Yes. And it's very common to be on an oral like metformin and an insulin or the Byetta, because the metformin makes you sensitive to the insulin. So if you're injecting yourself with insulin, it's going to make it work a little better, and also going to be a lower dose that you can get of the insulin.
Oh, okay. So now that we're on insulin, I think this was one that I took, Novolog. What's the difference between this insulin and some of the other ones you have here?
Okay. So this is Lantus, and this is a long-acting insulin, usually once a day. At bedtime, and that's because studies are done at night, and it helps to lower the fasting morning sugars.
Okay. So you said long lasting. What does long lasting mean?
Long lasting in this instance is 24 hours.
Okay.
So up to 24 hours, which is why you can only give it once a day.
Once a day.
There is a caveat to that. You can give it twice a day when you're up to 50 units or more.
Okay.
Because over 50 units, you don't absorb the whole dose.
Oh, okay.
So for people that may be taking 75 units, 50 units at one time, and 25 at the other, that's better absorption versus 75 units at one time.
Okay.
So this is a long-acting, and the Novolog is a short-acting. So short-acting being is going to be given multiple times a day, usually 3 times a day with meals, and it's going to cover those meals. Okay. So whatever you eat is going to be covered by the short-acting. Everything else that kind of gives you a baseline amount is going to be covered by a long-acting.
Now, let's say, like when I was taking Novolog, I had to give myself the insulin based upon what I'm eating. How does that work? Like, do I take it before or after? Sometimes I struggle with knowing exactly how to take it.
So what that really is carb counting. So you have to have planned the meal to know how many carbs you're going to have, to know how much insulin to give yourself. So you give it to yourself before, about 30 minutes or so before eating, to cover what you're eating, because it's going to go away really fast as well.
Oh, okay. So
normal fasting, and what we really want your numbers to be between 70 and 130. Anything lower than 70, we term hypoglycemia or low blood sugar. You start feeling shaky, can't think straight, jittery, sweaty, and having lows can cause coma. Yeah. So we definitely don't want you to get too low. And if you feel that way, it's always best to check.
Okay. I had 2 lows back to back, like 43, and then I drank orange juice, and then I don't know, it seemed like 30 minutes later it was back low again.
Right. So, and the important thing to remember when you do experience a low, when you do the thing to bring it back up, check it in 15 minutes. And if it's high enough, then you want to eat a small meal. Something that's going to have some protein and some fat and some carbs. Okay. And the one thing I like to tell people to do is eat like the peanut butter crackers, because it gives you all of that.
Oh, okay.
Because it's not, but if you don't do anything, it's going to make your sugar go up and go right back down.
Go right back down.
But with that peanut butter, the fat and protein, it makes it go up, but then it levels off so that you're not dropping down too low.
Well, see, I didn't have that information. So, you know, those lows are really scary. I always tell people when they ask me to describe what it feels like, I tell them it feels like you're walking in the valley of the shadow of death. Like, you just need sugar immediately. And I think a lot of times when people don't understand diabetes, they think, oh, you can't have sugar. But when you're having a low, you need sugar like in your veins. Which, is that what this is? Can you tell us?
Well, this is a glucagon emergency kit for low blood sugars. And this is those severe cases when you can't and you don't have the energy, because sugar is our source of energy.
Okay.
So when you're low and you don't have enough sugar, you don't have the energy. So a lot of times this will be given to you by someone else. And it's important, especially for type 1 diabetics, to have these on hand because they have more insulin that they have to depend on.
Right.
So the glucagon emergency kit can be, you have to have a prescription for it as well.
What does it look like?
And so it's actually a 2-step piece. It has a syringe, and it also has a valve that looks like it has a pill in it. So you have to insert the syringe into here, dissolve it, then draw it up, and inject it into the muscle. And that's going to bring the sugars up a little bit slower, but not so fast that you'll actually feel worse. But it's going to be something that's going to help bring up sugars in emergency cases.
Now, what about these glucose tablets? Like I carry them with me on my keychain. How is this different than the glucose tablets?
The glucose tablets have about 5 grams of carbohydrates in them.
Okay.
So to get the amount of increase you need to chew about 3 or 4 of those.
Right.
So the glucose tablets are going to absorb through your mouth when you chew them. And this is going to go into your muscle, which is going to take a little bit longer to be released. So you'll feel the effects of those glucose tablets really quickly, but not this.
Another question that I have is, if a person is type 2, if they have type 2 and they're prescribed insulin, does that mean that they failed somehow, that they're a failure, that they're given insulin and not just the oral medication?
No one's a failure. The good thing about insulin, as I mentioned before, is that it gets you better control faster. So being prescribed that and just being diagnosed should not be thought of as something, oh, I failed, I haven't been able to do what I need to do, so they're giving me insulin. It's not the end-all be-all. Many people can be on insulin and actually come off. A lot of misconceptions with insulin is that someone in their family had diabetes, and when they got insulin, they passed away. And that's kind of the older generation, because before we only had 2 medications for diabetes.
Oh, really? What were those 2?
So sulfonylurea, which is glyburide or glipizide, and insulin.
And were those both injections?
One was a pill and one was the injection.
So that was it. So we've come this far.
We've come a long way. And that was about 20 years ago. So we've made a lot of progress. And so what was happening was that we used the pill until we couldn't use it anymore. And what that pill did was squeeze the pancreas and get the insulin out.
So now I have a question. You said that the difference between having type 1 diabetes and type 2 is that in type 2, like myself, that means my pancreas still has some insulin that it's producing. But if these medications like squeeze it out, does that mean that, say, I could eventually become type 1? Like I have no more insulin left? Or how does that
If you're on the medications that squeeze the pancreas, it's possible that you can become insulin dependent. Which those medications are really falling out of favor because they do, wear out the pancreas, and we don't want that to happen. So medications like metformin work in a different way to make you more sensitive to the insulin you actually make. And also stop the liver from making it.
The pills communicate with the liver. Correct.
So it's very possible, if you're on like a glipizide or a glyburide, which are those that squeeze the pancreas, over time you will not have insulin.
And so insulin in itself doesn't squeeze the pancreas?
No. Insulin actually gives the pancreas a break. Because you're giving yourself insulin, so the pancreas doesn't have to work as much to make insulin. So it actually gives it a break, and in some people it actually rejuvenates and becomes better and starts working the way it's supposed to.
For today, those are all of my questions that I have. And if you out there have questions for Dr. Lewis in this segment, A Chat with the Pharm D, please email me and let me know, and I will do my best to get the answers for you. And remember, if you're a diabetic, you're diagnosed but not defeated. Thank you.
Black Diabetic Info is informing you.
If you would like to sponsor an episode of Black Diabetic Info and see your ad here, please visit the contact page for more information.